have to spell out Siddharth, so you will have to look through her bio to learn more about the organization. Rachel is a leader in developing evidence-based best practices in emergency medicine around the world. And she's going to talk to us about integrating high-quality emergency care in resource-strapped settings around the world. Let's welcome Rachel Rice.
Can you hear me? Yes. 3 weeks ago, in the northern province of Rwanda, close to the Democratic Republic of Congo, there was a bus full of a wedding party traveling to the capital city, Kigali. When the brakes failed, the bus overturned several times. 3 people died at the scene. The bride and groom were among those who died. The critically ill patients were taken to the nearby district hospital, or as we call it in the US, the community hospital in a rural area. But the problem in Rwanda is that there are no emergency medicine healthcare workers at rural areas or at university or referral hospital areas. Siddharth has been working since 2008 to develop health system strengthening and acute care under the auspices of ministries of health, utilizing task shifting and focusing on mid-level providers to deliver available, accessible, quality, and timely care. Let me share a few facts with you about Rwanda. In a country of 12 million people, there are less physicians than in my state, in my city, in my medical center? No. In my Department of Medicine at Columbia University, there are twice as many physicians in my department than there is in Rwanda, 694 physicians. If we look at how specialists are listed up there are only 166 specialists, and none are emergency physicians. In Rwanda, we have this health pyramid that we have in every country, right? And it looks very similar. In medicine, when we want to improve things, what do? We focus on the top of the pyramid, at the referral hospitals, or university hospitals, as we call it here. We focus on building specialists and having training programs that train. When we want to improve public health more broadly, as we do as a public health practitioner, we focus on the bottom of the pyramid and the essential community health workers that deliver vital services like family planning and bed nets get more and more put on them because we have a paucity in the middle. Rwandans are 80% rural. 80%, like most sub-Saharan African countries, although there's a lot of shifting now. In Rwanda, 75% of the deaths happen where? At the district hospital level. 5%, probably because they're dying at home, die at the health center level. And 20% at the tertiary level. Siddharth's been working on the center of that pyramid to develop health system strengthening of emergency care that permeates the health system to reach both the top and the bottom. So, what is the solution in Rwanda? Well, it's to provide available, accessible, high quality, timely care to all Rwandans at every level of the system. And to do that, we've done that by doing one thing, introducing emergency medicine as a specialization. And like a multivitamin, emergency medicine has all specialties, whether it's orthopedics and dealing with trauma, or a toxicological emergency, or a pediatric emergency. You don't need 100 specialists. You have one person, and even yet, So, the Ministry of Health tasked Siddharth to do just that. They said, we need you to take our general practitioners in rural areas and give them a diploma through the Faculty of medical school in the whole country, through the University of Rwanda, Faculty of Medicine, a one-year training program for rural docs to know emergency medicine. Because everybody else is developing these 4-year specializations at the top of the pyramid. We might not need 4 years. So we did just that. But we realized, oh my gosh, the ministry said you can't take them for the full year to Kigali to train them at your university hospital or where you're going to put your specialists. And we said, okay, because of the genocide and because of other programs for those specialty programs, there was a paucity of GPs. So we did a sandwich program, 3 months out in the rural district where they're serving their communities, 3 months at the university hospital where we're training them. And the ministry did something else. They said at the end of the program, we're going to increase remuneration so that they will be paid higher than a GP. And we will subsidize and cost share the time that they're training with you. So we'll pay their 100% salary, even though they're only working for us at the district hospital teams. Great. Let me share with you one of the impacts that one of our rural GP students had in his facility. After only 6 months of training in our program, after a year, he redesigned his district hospital emergency department. He trained nurses in triage and trained all of the wards in acute care and state and resuscitation. He treated higher levels of care and didn't refer people, which increased reimbursement through the national insurance scheme and caused the hospital to have greater funds come to the hospital. He increased satisfaction of the healthcare providers because they were now saving lives. And the hospital said, we want you to have this cascading effect because we want to actually get referred from the health centers faster with better clinical acumen. Can you please use our money that we're going to give you from our district hospital, which is unheard of, and we're going to ask you to train all of the health centers. This didn't come from SICART programming. This came from the success of this practitioner to motivate this hospital to do this. When the ministry came to us and said, we value your program, the Faculty of Medicine has this other program that they're going to develop specialists in the capital. Emergency medicine will be a 4-year program. What do you think about that? We said, well, why do that? Let's join hands and have a hybrid program. And they did something unprecedented. They spoke to the Clinton Foundation and the Faculty of Medicine and SIDHART and the ministry themselves, actually, after a bunch of no's, said, yes, we will do this together, and your PGD, your diploma course for rural docs, will be considered the first year of this 4-year specialty program, so that we can have and work ourselves out of a job, the specialists of the future, the faculty of the future that will lead Rwanda in this effort to be the preceptors and the trainers of those rural district GPs. We said, great, let's do it. I want to also tell you about the impact that we had directly on Rwandans' lives by another student, GP, also around a year in his training, which was 6 months because it's tough time. He was in his northern rural district hospital during his 3-month stint, when on Saturday, on a day off, he was drinking his coffee. He got a call from the district hospital, the community hospital, and they said, come in quickly, there's a bus that overturned, and there's a wedding party that's streaming in with critically ill, injured trauma patients. He ran in, he set up mass casualty response, set up triage, called in providers from home, got blood from a neighboring hospital because they had stocked out, and he attended to his first patient who had severe head trauma, was not breathing well. He assessed his patient through a rudimentary and systematic trauma examination. That's him. That's Dr. Ezekiel. He's training nurses here, but he attended to that head trauma patient. He intubated, put a tube down the trachea, attached that patient to the ventilator machine, applied oxygen to the patient, stabilized him, and transferred him successfully to the University Hospital in Kigali, where the patient lived. The next patient he saw was kind of quiet, but holding her abdomen. Quiet ones are the scary ones. The ones that make noise, she had something going on. He did his trauma assessment. He used his emergency medicine, ultrasound skills, his imaging skills to find that there was blood around the spleen and this patient possibly had splenic vasculitis, which couldn't be taken care of because the one other, or there was a few in this hospital, general practitioner was doing a C-section in their operating theater. So, and they don't do trauma surgery at this hospital. So he put IV blood from that other hospital, stabilized that patient, and transferred her to Kigali, where she had emergency surgery. A few other patients had abdominal bleeding as well. He transferred successfully. They all survived. The greatest impact our program can have is on this cascading effect to contribute to the Rwandese taking leadership, the Ministry of Health designating this dual system of creating these specialists for the future and addressing that 75% of death in the district hospital. Because those specialists in many countries are not gonna never make it down. They get trained, they leave, they go out, they don't come down to the district level. So that we can take care of urban and rural acutely ill patients